Good morning, everyone. Thank you for participating in this very international session. We have speakers joining us from Brazil, Costa Rica, Cuba, and Louisiana. When we planned this session, we still had a chance that we could do it in person in Houston, and we were planning another event here in New Orleans at Tulane University School of Public Health and Tropical Medicine. And I was hoping that we would all be traveling on a road trip from New Orleans to Houston. But instead, we are here together virtually. And I have the privilege of working in different capacities with everyone who is part of this session. And this session also is a great segue with what Dr. Lopez-Gatell was explaining about the situation in Mexico, in which the pandemic has highlighted a lot of the weaknesses of existing health systems, such as the underfunding. And also, very obviously, the pandemic has highlighted the conditions of daily life that are structural drivers of inequities and a source of health inequities along the social gradient, as Sir Michael Marmot often reminds us. In a study that we are conducting since last year at Tulane University, along with the University Santiago de Chile, the ISLAC project, we are conducting research on the indirect effects of the pandemic on services for women, children, and adolescents. And throughout the region, a lot of the healthcare that are provided daily to this demographic group. And I remind everyone that every day we have children who are born, and every day there are women who have obstetric complications, and there are children who need care every single day, and adolescents who also need multiple types of services. And those services have been affected dramatically by the pandemic, and again, reproducing any pre-existing inequities. And today, we are going to have an overview of the context in different parts of the region. And I also going to introduce each speaker right before they speak. And for everyone who has questions, please write them in the Q&A feature. And we will discuss the questions at the end of all the presentations. So I'm going to now introduce our first speaker, Dr. Paulo, Professor Emeritus at the Oswaldo Cruz Foundation, Cruz, in Rio de Janeiro. And also he's the president of the Latin American Alliance of Global Health, ISLAC, and a member of the Brazilian Academy of Medicine. Please, Dr.
Thanks, Arachu. Good morning, good afternoon, good evening for everybody. I'm very happy to meet Carina, Rocío, you, Arachu, and Juan. Very, very nice friends in this very international group, very international seminar. And very happy to talk about the situation in Brazil. Please, Arachu, can you show the presentation? Okay. Thanks so much. I started to say that Latin America is not the poorest region, but certainly is the most unequal in the world. And Brazil stands out among the most unequal in the region, and therefore in the world. The Latin American countries, Brazil, between them, face challenges on various fronts to control the pandemic. The economic and social effects of COVID-19 are aggravated by pre-existing structural problems in the region. And they mention high levels of inequality, labor informality, lack of social protection, poverty and vulnerability, weak and fragmented health and social protection systems, marginalized urban settlements lacking access to basic services, large migratory flows and population displacements, and last but not least, a climate crisis. Next slide, please, Arachu. Well, retrospective studies show that since the times of colony in Brazil, with accentuation throughout the 20th century and with ups and downs in the first 2 decades of the 21st century, social and economic inequality is a structural and historical landmark of Brazilian society. With the rise of progressive governments of President Lula between 2003 to 2010 and President Dilma Rousseff from 2011 to 2016, when it was interrupted by a questionable impeachment process, we know, and both belonging to the Workers' Party, Brazil has an improvement in indicators such as poverty reduction, improvements in the Gini index, and the Human Development Index. And this performance was the result of deliberate social and economic policies from progressive government with programs such as Fome Zero, Hunger Zero, Bolsa Familia, and many others. But after the impeachment of the progressive government of Dilma Rousseff, but also following trends throughout Latin America, this is true, Brazil started to worsen its indicators of poverty and inequality between 2017 to 2020. And this we can see on the next slide, please, Arachu. Okay. Here we can see the sustained growth of poverty and extreme poverty in recent years in the country, reaching more than 40% of the population in 2020. The proportion of poor is more than double between Black and brown men and women. Access to education is worse in families headed by Black and brown men and women. The same occurs with access to social protection programs, and finally, access to adequate housing conditions, as well as water and sanitation, is lower in families led by Black and brown men and women. The next slide, please, Arachu. In 1988, Brazilian Constitution defined health as a universal right and state responsibility. Progress towards universal health coverage has been achieved through a unified health system. We call in Brazil Sistema Único de Saúde. The acronym is SUS, which was created in 1990. With success and setbacks in the implementation of health programs and the organization of its health system, Brazil has achieved near universal access to health services for its citizens. The trajectory of the development and expansion of the SUS offers valuable lessons on how to scale universal health coverage in a health system in a highly unequal country and relatively low resources. The analysis of the 30 years since the inception of SUS shows that innovations in the Brazilian health system extend beyond the development of new models of care and highlights the importance of establishing political, legal, organizational, and management-related structures and the role of the federal and local governments in the governance, planning, financing, and provision of health services. The expansion of SUS has allowed Brazil to rapidly address the changing health needs with dramatic scaling up health service coverage in just 3 decades. However, despite its successes, analysis of future scenarios made by our group with Cruz in 2017 and in 2018 already suggested that urgent need to address lingering geographic inequalities, insufficient funding, and the suboptimal private-public collaboration. and restrictive fiscal policies implemented by the current Bolsonaro's administration after the beginning of 2019 that ushered austerity measures and bad, I can say, no adequate environmental education and health policies could reverse the hard-earned achievements of the SUS during the progressive governments and treating its sustainability and its ability to fulfill its constitutional mandate of providing health for all. Next slide, please, Arachu. Well, the outbreak of the pandemic in the country February 2020 occurred in a difficult political situation, with the country divided in the face of radicalization in the post-election year 2019, the conservative positions of the new government in the field of customs, for instance, and even the restrictive economic and social policies, very restrictive austerity, but restrictive policies implemented by the Bolsonaro government. And such policies led to a worsening of the social situation, and the pandemic worsened it. The policies worsened the social situation, and the pandemic clearly worsened this already bad social situation. The federal government took positions to deny the pandemic, as did President Trump in the United States. But unlike Trump, who at least purchased a large number of vaccines, the Brazilian government was silent on this and other aspects of coping with the pandemic. Governors and mayors, each in their own jurisdiction, began to lead the fight against the pandemic. But the lack of coordination of actions led to growing chaos in the pandemic in Brazil. The result of this process is that today Brazil occupies the epicenter of the pandemic in the world, having overtaken the United States and constituting a global threat, including due to the emergence of a more contagious variant of the virus in Amazonas, which is already prevalent in infections in our country, but it's crossing borders, as you know. The consequences of the pandemic are the worsening of the economic and social situation. And I can example with the record unemployment rates that in 20 of the 27 Brazilian states reached 20% of the population, and more people being thrown into the informality of work and in a very, very difficult economic situation. Emergency financial aid paid by the federal government in the second half of the 2019 partially mitigated the situation at that time. But since January 2021, such financial aids has been suspended and social difficulties have reappeared with unemployment, hunger, child malnutrition, and an increase in infections to an unprecedented extent. The last slide, please, Arachu. For a week, Brazil has had more than 2,500 deaths per day. The hospital intensive care system no longer has available beds. Many people are dying waiting for an intensive care bed. Many deaths are beginning to occur at home as people give up looking for hospitals. And for sure, the poor population is the most affected by this situation. Vaccination advances in a very slow process due to the lack of vaccines not purchased at the right time by the federal government of President Bolsonaro. Although the excellent infrastructure for primary care and vaccinations remains intact and well-structured due to the work of the professionals, the health professionals, just waiting for more doses of vaccines to arrive, not purchased by the federal government of President Bolsonaro. In conclusion, despite its reasonable public health system with great capillarity in primary care, the current federal government will bear the terrible burden of being responsible for the more than 270,000 deaths and 15 million multiplied by 4, certainly, I mean, 50 million cases already occurred in Brazil of COVID-19. Even official registry that now in the country is only 50 million cases. And finally, the case of Brazil clearly shows how a country with great social inequalities hardest hit by the COVID-19 epidemic, and how this disease can further worsen the economic and social inequality of the population. Thank you very much for your attention.
Thank you very much, Paulo. It is now my pleasure to introducing you to Dr. Rocío Sáenz. She is a professor at the School of Public Health of the University of Costa Rica, the director of the Health Equity Network of the Americas, and former Minister of Health from Costa Rica. Welcome, Rocío.
Thank you. Good morning, good afternoon, good night, wherever you stay listening to us. For me, it's an honor to be here, and also I want to please and say thank you, Dr. Arachu and Tulane, and of course the CUGH 2021 to bring us the opportunity to share this session. We expect to be together and have the opportunity to see each other, but this pandemic changed everything, but not the feeling that we have to share today with you. As mentioned, first for Arachu and Professor Booth, our context in Latin America is very, very different than the other parts of the world. We have a high population with poverty. That means that the people doesn't have the opportunity to satisfy the needs for their own person and for the families, and high informality, and a gap for education, not only the coverage, but also the quality of the education system, and a special gap for the access for the internet. Also, we have documented several points of corruption, not only at the government as a whole, but in instance in our health system in the region. And our health system are underfunded, fragmented, segmented, and with limited capacity in primary healthcare and ICUs. The investment in health with an emphasis on complex form problems make the balance between the health promotion, prevention care, rehabilitation, and palliative care far from being a reality. When we try to understand the response in our region, we found the gaps, a big gap in the training health professionals, in the infrastructure, equipment, and the ability for the PPE emerge as a big problem and a big concern. Attention to the reactive pandemic by a conjuncture is not enough and not sufficient. Little or no preparation has led to oversizing and imbalance towards of the response for severe cases. The inconsistencies and the incoherences of the measure do not favor adherence and consistent social response. And it's the root of the uncertainty of this at this moment. Tiredness, frustration, exhaustion, and risk in physician in emergency rooms in intensive care units for the COVID-19, it's one of the biggest problems that we have to handle. The learning and questioning of the generation of knowledge is contrasted by the society generation both trust and uncertainty. Illness and deaths counted and added statistic is necessary, but is far from the suffering of the citizen. The next, please. Public and international response to the crisis, we can find some initiatives. This is, of course, I don't try to be completely all the initiative, but I choose some of them that to show the difference that we have all over the region. Attention and protection of the vulnerable groups, older adults, migrants, indigenous population, population with risk factors, workers in the long-stay shelters, and among others. Also, the protection of the health workers. Telemedicine was one take the opportunity to arise a possibility to extend all over the region, and also the prioritization of the patients with the NCDs, HIV, reproductive health, pregnancy, cancer, and children. We really don't know the impact of those pathologies and those populations. But there is still to recognize that the prioritization, the protection of the life has social, economic, and political effects. The lack of protective equipment for the healthcare professional should not be nor is unacceptable. Scientific collaboration for epidemiological surveillance is insufficient. We have to include the genomic surveillance because we know right now the different variants are coming, and this is, we have to handle it. And access to vaccine should not be contingent on ability for the people who can pay. Even if those are the countries, we have to build some kind of different forms to respond. The next, please. Make the commitment for we cannot return to the previous normally. We must make a step toward more equity and social justice. We must recognize that the pandemic control is necessary, but it's not sufficient. It is necessary to address the inequities and have been shown and deepen it. A comprehensive response, not by conjuncture. The health has to be really a comprehensive priority. Achieve autonomy in the first response, especially for the poor countries, has to be in the center of the table of the discussion. Build some emergency funds for equipment and emergency supplies is a mandate. We have to take this clearly. Protect first responders, medicals, trainers, protectors, and increase the motivation of the people. The health workers, our doctors, our nurses, they are not only workers, they are a person, has to be motivated. Deploy protocols, standard, and procedures. Of course, we needed that, but we have to build with the people who has to implement it. Promote great accountability and participation of the various actors. It's in the center of the social determinants of health, and sometimes we feel that there is some groups comment that is impossible, but we think this is not impossible. It's because sometimes it's better to go alone and not include the people in the response. Risk information and communication plan they have to be in the center of the response. And of course, the universal access to vaccine is an imperative, but they are not enough to address the inequalities previous and deepened by the pandemic. For my last slide, please. The most important message I want to share with you is that this also will require governance and leadership based in global solidarity to address the causes of the inequalities. Thank you.
Thank you very much, Rocío. I am now happy to introduce you to Dr. Juan Garai. Juan has extensive experience on global health policy, and he has spent the last few years living in different parts of Latin America and the Caribbean. He's an adjunct professor at the National School of Public Health in Madrid, Spain, and also an honorary professor at the Autonomous University of Chiapas in Mexico. He's joining us from Havana, Cuba.
Hello, good morning, afternoon, evening to all colleagues and friends meeting throughout the world. I'm really honored to try to motivate you during some minutes with the tragic levels of inequity in the region and how they are being worsened by COVID pandemic, and the opportunity to transform our societies and the international governance, learning from the experience, from what the pandemic is already telling us. In the few minutes I will be talking to you, I want to share some new ways of looking at inequity. Inequity is the unfair distribution of inequalities, and it relates very much to our only common global commitment on health, which is the WHO, the World Health Organization Constitution founding article, which states that all countries will strive and will commit to the best feasible levels of health for all people. So the first thing to do is to think about what does it mean, best feasible level of health. It is certainly not what we've been running after during the last 50 years, which are development models of high income industrialized countries based basically on constant economic growth and constant growth on global trade, and with a very high price in global warming and what it will mean most likely to the next generation in the second half of the next century. So if those development models like the US and the EU are not the ones to go after, because first of all, they are based on premises that are undermining the natural resources for the coming generations, but also they are counting on economic resources which are far above the world average, and therefore they cannot be replicable to all. So we looked at other countries, and we've done that for the last 15 years, that have good levels of health above world average, life expectancy, healthy life expectancy, and other indicators. But they do it with economic means which are not above world average, and very important, they do it with carbon emissions per capita, which are below what we call the ethical threshold, above which we are deemed to global warming with dramatic effects. In fact, we have calculated that in the second half of the century, just by temperature increase, the excess mortality will be well above 200 million deaths, and mainly in countries which are low in carbon emissions, and in the generation that has been born after 1990 and is probably less responsible of what we're doing to the planet. So these huge inequities can be reflected in a methodology, identifying first at international level and then at subnational level regions of the world, or countries or regions or communities that have life expectancy, as I said, above the average, while using resources below the average and carbon emissions below the threshold. here you will see in these slides, in the upper left side, how life expectancy in women in the orange bars is Latin America and the Caribbean, has been slightly higher than the world average. So one could say in general figures that Latin America and Caribbean are not doing too bad. They're just slightly above the world average, both in women and in men on the upper right. And they're doing that with GDP, with economic resources below the world average. So they seem to be healthy and equitable models, although you can see in the lower right chart that carbon emissions are now, since the turn of the century, above the ethical threshold. So Latin America is no longer in collectively ecologically sustainable region, and it needs to not only not follow the high income models, but also reflect on its own model. Can you press the next one, Arachu? Thank you. So in this slide, you will see that when we take models in the world, I don't have the time to go into detail. We have been doing that every 5 years when we have new data from the UN Population Division on population and deaths by age group, by country, by sex. And we can compare those mortality rates with those best feasible models of good health using moderately economic resources and respecting nature. And it's interesting to see that in Latin America, the burden of health inequity, which is that excess mortality from the expected one of those equitable models, was being reduced since the 80s until the turn of the century. That was not in national averages. It was not a bad time, but since the turn of the century, it was already on an uptrend. And we have just last week analyzed the last set of data from 2015 to 2020, and it keeps going up, even if we do not take into account the impact of the COVID pandemic. So there is a worrying uptrend in the burden of health inequity, which means the excess mortality from those feasible models. In fact, those feasible models have a GDP far lower than the Latin American region, and there would be enough resources without even economic growth, but with a different economic structure to prevent all these deaths, these over 1.5 million deaths a year, preventable just on international averages. Compared with feasible standards, with equitable standards. If we look in the upper right chart, you will see that when you break down the burden of health inequity in Latin America collectively, between women and men, male and female, it was higher in last century in men, but it is now growing in women. And as we and in the last 20 years, it's growing the number of excess deaths in women. But this is even, you will see later that the proportion of deaths which are preventable, which is the relative burden of health inequity, is even far worse in women. This is interesting because this trend is almost parallel to what you may see in the economic outlook, for instance, of poverty trends in Latin America. The economic outlook was published last week from the Economic Commission for Latin America. And there is a very strong correlation between poverty, of course, and excess mortality in women. In the lower graphs, in the lower left graph, you can see how the number of deaths has been shifting from mainly a high burden in the under 5s and in children in the 60s, to a more evenly distributed, affecting more adults and with high adult mortality. That's why probably it doesn't show so well, and life expectancy seems to be on a good trend, while excess mortality, particularly in adults, is very high. And you will see in the lower right chart how in the last 5 years, when you compare the burden of health inequity in women and in men, you again see a high excess mortality in under 5s, but then it gradually grows in women, and it's basically following almost like a normal distribution curve in male, whereby after the reproductive age, it tends to be lower. But in women, particularly after the age of 40, there is a very high burden of health inequity. Now, this is the last slide with figures, and I'm sorry to probably bombard you with so many data, but this is very important. This is the most sensitive indicator, in my opinion, of health inequity, which is the relative burden of health inequity. It means what is the proportion of all deaths that could have been prevented by equitable models. So to say, the proportion of deaths due to injustice, and probably the most sensitive barometer or indicator of injustice in any society. And you see that before the turn of the century, it was around 20%. It came down to almost 10%, but it grew after the turn of the century, and it keeps growing. And like you see in the upper right graph, it's growing more and faster in women, and as a sign of inequities, not just socioeconomic inequities and large territorial inequities in the region, but also gender inequities. And you can also see with this indicator, the relative burden of health inequity, how the proportion of, let's call it, unfair preventable deaths is again, has been growing since the 60s, although the net burden of health inequity does not show so clearly. And it is affecting more and more people from 15 to 50 years of age. And that is lagged on till 65 and 70 years in women, as you can see in the lower right graph. So no more graphs. These are the conclusions on social determinants of health and the COVID pandemic. One, structural socioeconomic inequity and the burden of health inequity, which has been increasing since the turn of the century and very clearly in this last decade, has been fueling COVID transmission and lethality, as rightly Paulo and Rocío were exemplifying with the experiences in their countries. And conversely, the COVID pandemic and its economic impact is bound to increase the excess mortality, the overall excess mortality. We know that economic growth over 5% normally is paid with the price of higher Gini, but we now know much better that when there is a baseline high Gini, the economic crisis are also increasing. Sorry, Arachu, can you pass to the next slide?
Yes, Juan, I'm sorry, but your time is up. It'd be great if you could wrap up.
Yes, I'm wrapping up, but
this one?
By increasing Gini, increasing poverty, and all the impact in health inequity. The COVID pandemic has caused, it says here, 1 million deaths. It's really 700,000 deaths in Latin America, but it is probably over 1 million, we've estimated, if we count the excess mortality due to other causes by the pandemic, the economic impact and others, probably more than 1/3 in Brazil. And it is most likely going to continue to grow in the next 5 years. The last point is that COVID-19 vaccine inequity in effectiveness and coverage may mean an extra 1 million preventable deaths in the region. So we have a triple dimension of inequity: the COVID pandemic itself, the structural inequities, and the inequities in access to vaccine. And we need, in the last slide, sorry, just 30 seconds more, Arachu, sorry for that. We need a structural change through fiscal territorial equity to reduce Gini, poverty, vulnerability, universal access to social and health services, epidemiological and intelligence services. We don't know enough what's going on with the dynamics of the pandemic, and collective research and development efforts to develop global public goods as COVID-19 vaccines, free from market dynamics and aimed at universal and equitable access. I say that from Cuba, which is developing vaccines with public funding aimed at universal access, and in comparison with the world, which has been really trapped by market dynamics, benefiting the rich and replicating the huge inequities between and within countries. Sorry to have gone beyond the time. Thank you.
Thank you very much, Juan. It's now my pleasure to introduce you to our last speaker, Carina Vance. Carina is a doctoral student at the Tulane School of Public Health and Tropical Medicine. And she came from Rio, where she was the executive director of the South American Institute for Government in Health. And prior to that, she was the Minister of Health of Ecuador. We're very pleased that Carina is at Tulane. Welcome. Please go ahead, Carina.
Thank you, Arachu. It's really great to be here with Juan, Paulo, Rocío, and everybody who's listening. Well, I wanted to propose looking at this from a social determination of health perspective. I think that it's, from the Latin American perspective, we have such a rich, a contribution in terms of how to explain exactly what Paulo, Rocío, and Juan were talking about. How do we achieve structural change? We have to focus on structural change. We have to focus on those power dynamics that are occurring globally and locally. And my presentation is going to be a bit more geared towards the regional context. Now, if you can go to the first slide, please. So I wanted to share a bit of what we've already seen. Here we see a map of cumulative cases. This is Johns Hopkins dashboard information, where you see, United States and the rest of or Latin America having, an important burden in terms of cumulative cases. But when we look at case fatality ratios, we see the differences in terms of what is occurring regionally. In terms of excess deaths, Juan already talked about what they mean. The highest excess deaths rates in the world are in this order: Peru, Ecuador, and Bolivia. And this is something that's very telling of what is happening. Part of what we have seen regionally in these last few years is reduction in terms of health budgets. The region has, the previous goal of reaching 4% of GDP in terms of public spending on health. And what we've done in the last few years is actually go backwards. We're decreasing funding. I'm going to talk specifically about Ecuador, maybe with some examples, because that's where I'm from. But we had in 2020 a 10% decrease of the health budget, public health budget, in 2020, in the year of the pandemic. And this is the one of the contributing, I guess, to frail health systems, debilitating health systems that cannot respond to the pandemic adequately. So I wouldn't, the pandemic is a worldwide, situation that we're experiencing, but the situation that's being experienced in Latin America is particular, and it's particular because of these types of things. Cuts in terms of health personnel, diagnostic tests, for instance, the lowest, some of the lowest rates in the world. We saw personal protective equipment, for instance, for our health personnel in hospitals and in health centers that was absolutely deficient, with doctors, nurses, et cetera, having to use, masks for weeks long, something absolutely opposed to what the protocol establishes, because they didn't have protective equipment. And at the beginning of the pandemic, there was a dispute in terms of resources, and you could, in a way, understand because of the global power dynamics that Latin America couldn't access enough resources. But now we are seeing that this trend has continued in some of the countries in Latin America, and it is no longer due to this original dynamic in terms of resources. And now what we're seeing is the same dynamic with vaccines. You could pass to the next slide, please. Thank you. So here's some additional examples. Dr. Tedros from the WHO has referred to what we're experiencing as a catastrophic moral failure. And here you can see in the first graph on your left, population by economic status as defined by World Bank indicators versus the purchased doses of COVID vaccines. As you can see, in high-income countries with a population of 1.2 billion people, 4.6 billion doses have been purchased. Upper middle income, 2.8 billion people versus 1.3 billion doses purchased. Lower middle income, which is probably the most stark inequity or difference, right? 2.9 billion population versus 608 million doses purchased, and then low income countries with 668 million population, 670 doses. This is data from the World Bank and also Duke University Global Health Innovation Center. And then when we can see on your right is the percentage of population fully vaccinated. This is probably not current to this day, because for instance Colombia has already started vaccinating, but you see the highest percentages in the region. This is only Latin America, the Americas, the region of the Americas, and you can see that there is certainly a difference between high income countries and the rest of the region. There are some high income countries in the rest of the list that have not yet accessed vaccines, but evidently there's a concentration in terms of that. Can you pass to the next slide, please? So I'd like to talk or have, propose a question. What is the role of international agencies and organizations? And is there a growing conflict of interest? The WHO in 2020, everybody saw the impact of the decision by the US government to do away with the relationship with WHO. You can see on the slide, this is a graph that was published in The Economist, but basically where WHO funding is coming from, right? The vast majority, or the biggest proportion, comes from the United States, followed by Britain, the Bill and Melinda Gates Foundation, Gavi Alliance, Germany, et cetera, et cetera. So when you have this structure of financing that is so dependent on countries, on different countries that have, as you can see on the other graph, we can see the biggest pharmaceutical countries, the highest earning pharmaceutical countries in the world, and the countries where they come from. One has to ask, or what we're asking from various groups in the South, I'd say, is to what degree can we depend on an organization that depends so heavily on financing, that is interested in, that has implicit ties or commercial interests that we have seen being played out in the midst of this pandemic. Excuse me. In terms of the Pan American Health Organization, we're questioning also what is happening in terms of the effect of the lopsidedness of Pan-Americanism. The fact that, for instance, as an example, PAHO has the first authority that is decided upon by all of the members of PAHO, all of the member countries, but the second authority is always from the US. Why is that? Well, we know why that is, right? Why is PAHO's headquarters in Washington? And I have a question also to ask. Why hasn't PAHO supported regional production of medications more? We've seen great technical support from PAHO in many instances, and I can't deny that. And I also, if we have people from PAHO accompanying us today, I greet you. This is not a personal questioning, but it's a questioning about what role it has played. And we saw in 2020 also the case of the U.S. government following a criminal process against Paulo due to basically saying that there is human trafficking going on in the case of Mais Médicos. No, this agreement between the Cuban government and the Brazilian government to have 15,000 Cuban doctors support the Brazilian health system, especially in those places that are hard to reach, that have the biggest gaps in terms of health personnel. And we saw the U.S. and we still see the U.S. and the Secretary of State in last year saying that they were contemplating withdrawing from Paulo, and that they froze their contributions for I think it was 2 years. So Paulo, we were also witnessing what the power of certain countries in the context of the situation of the rest. And then this issue of the IMF, International Monetary Fund, the role they had in Argentina until Alberto Fernandez assumed the presidency, and in Ecuador. I'm going to talk again specifically about that example, but basically the return of neoliberal policies that were part of the reason why we had a 10% budget decrease or budget cut in the health budget of Ecuador was because of the agreement with the IMF. And that agreement is still in place, and we're still seeing health budget cuts and personnel cuts. We had people, medical doctors being fired from their positions in the public health system because of the IMF agreements. And this is something we have to think about. The next, please, Arachu, my last slide. So what my proposal here, I think there was a question also related to, what can we do about these structural issues that are deepening inequity? And I'd say that one view from the South is, the need to strengthen regional health sovereignty. In terms of, again, talking about social determination of health, how do we counterbalance global hegemonic powers? Because, reaching the type of objectives that we have heard from Juan, from Paulo, from Rocío, we're not going to be able. There is I think a line of thought in the region that says we're not going to reach that. We're not going to be able to do it if we maintain the structure as is, and if we do not organize ourselves as Latin American countries to counterbalance the power and the pull of and the influence of the US and Europe, we will not achieve these goals. Now, a case for regional integration mechanisms, just briefly talk about the successes and the demonstrated potential of UNASUR. Just an example, we were able to implement a system shared by the 12 countries that were members at the time. This was in 2016, where 34 medicines and vaccines, 34 that were agreed upon by those 12 countries, we were able to put the prices that each of the 12 governments had obtained in buying and purchasing those medications. When that was made transparent, we realized that if we were to buy those 34 medications, at the price, this is a theoretical exercise, by the way, but it's an important, I think, exercise. If we were to buy those 34 medications at the price, at the lowest price that one of the 12 governments had obtained, based on the demand, the verified demand of those 34 medications in the 12 countries, we would be saving regionally $1 billion. $1 billion, only 34 medications. Imagine what that would be if we were to share our information in terms of pricing, and now not even talk about vaccines and the horrible contract that we're being submitted, that we're being forced to sign in the various countries that are just leaving all the risks on the countries. The companies are assuming no risks. So this is just to show the great potential of regional integration and the reason why there was an attempted destruction, right? Brazil, government of Ecuador, Argentina, Chile, everybody started leaving, right? Saying that it was too ideologically, compromised, etc. And I think that one of the reasons is because of the demonstrated potential it has. So the proposal, one of the proposals I think is reviving UNASUR, reviving regional integration mechanism based on what we have learned, sadly, because of the horrifying situation we have lived through in Latin America during the COVID pandemic. Thank you.
Thank you very much, Carina. And we have time for a few questions. I'm going to read one of the questions comes from Dr. Keith Martin, Executive Director of the Consortium of Universities for Global Health. And I'm going to ask Dr. Rocío Sáenz if she can address this question. What is needed to increase collaboration between Latin American and Caribbean nations in the Organization of American States and the Pan American Health Organization? And there is a related question also by Dr. Martin at the end. How can the OAS and PAHO be strengthened to facilitate regional efforts to address common challenges?
Thank you. I would try to respond to this important question to put in the table that I am a woman from Latin American public health with experience in policy, in health policy, but also I came from a country that for a long time are doing the thinking health and the society different than the other countries. And for that, for me, it's very important for this question to really put in the minds and in the different professionals of the health workers and the different institutions, the importance of the equity. The equity, how to strengthen. Equity has no be more the only illusion and only be as a ideological point of view. It's really an imperative ethic to really put in the center the people, not only the interesting for the some groups. And for that, I think if we can build some kind of group that they can work with the equity, not only to measure the equity, how to respond how the equity is included in the response for the health system and for the health policy. I think we can move a little bit more than we are today. But also we have to work intersectoriality. It's not only the responsibility for the health workers. The inequalities is in the essence of the society. And for that, I would like to have a group to working on that, supported with fully planning how to handle this issue in Latin America, and maybe we can share with another countries and other regions, because the inequality is not only in Latin America. The inequality has shown and arising also in the United States with the African and the Americans and the migrants and others. And we think if we really face the challenge we have today is to do the the things different that we made in the past. This is my...
Thank you very much. We have time for another question that comes from Marwa Saleh. And I'm going to ask Dr. Bus to address it precisely because he's very familiar with the topic, and also because, Paulo, you were a commissioner of the social determinants of health in the Americas and health inequities at the Pan American Health Organization. So the question is, it would be great to hear our panelists' perspectives on the movement led by the Global South, promoting the approach of social determination of health rather than social determinants, where the social process dynamics are emphasized and risk factors are less center stage. Dr. Booth, please. You need to unmute.
Yes, I think this approach of the determination and not determinants is much better, because the situation is, we have a very important set of explanation coming from the social, economic, and environmental conditions. And the central question, it's the current development of the neoliberalism, the capitalism, and the forces of capitalism in the global situation, and this is determination and not determinants. So I can say that the reason of pandemic, the origin of pandemic, is the way of development, the way of consumption and production that we have in the current stage of capitalism. So I think the world is, the people, the authorities, the governments are thinking to come back to the old situation. But this old situation comes to the current situation of pandemics. And if you not change the state, the forces, the international forces of capitalism, the forces of the market, the force of the state, we will have even more new pandemics like the coronavirus of this pandemic. It's my concerns in this sense.
Thank you very much. I want to thank all the speakers for their wonderful presentations and extremely relevant to what is happening to all of us right now. And I apologize to those questions that we couldn't address live, but I encourage those people who with answers to contact directly the speakers if they would like to have additional information. So again, thank you everyone, great presentations, and thank you to the Consortium of Universities of Global Health for allowing us to have such a session. Thank you.